Hello, my dear students. I'm Dr. Vaishali Bharambe. I've been teaching anatomy for more than 25 years and I love it. Today, I'm bringing to you my favorite topic, anatomy of uterus. I've told my students many times that the very reason why we have so many medical colleges in India is because we need more and more doctors to treat so many of the women patients whose problems remain unaddressed throughout the interior of our country. If you don't know uterus, you probably have no business becoming a doctor. That's my personal perspective. I'm sure there are other viewpoints to this, but let's talk about the uterus today. Remember, for all my lectures, MCQs and notes for every topic are available in the form of handouts on my website vbanatomy.com. Please access them and use the notes as well. This is in response to all your appeals that ma'am, we want notes as well. So, okay, here are the notes. Okay, right. So, anatomy of uterus. Remember, the ovary and fallopian tube topics are already covered, and now we've come to the uterus anatomy. Take a look. So, this is the uterus here, which is somewhat inverted pear-shaped structure. Obliquely placed, you can see that here. Thick-walled muscular organ related anteriorly to the urinary bladder, posteriorly to the rectum. I'm sure all this is so easy that I'm assuming you're understanding this. The primary function, of course, is to provide area for implantation of the embryo and the area where embryo can be taken care of for the next 9 months. The uterus communicates on the side with the fallopian tubes and inferiorly with the vagina. This is the introduction to uterus. Math is always something we have to deal with. So let's talk about measurements. The uterus measures about 7.5 centimeters, cervix being 2.5, a total of 10 centimeter organ. The ratio of body of uterus to the cervix in an adult is 2:1, but surprisingly in a child, in a newborn child, it is 1:2. Uterus is small and the cervix is long. Isn't it amazing? The breadth is about 5 centimeter with a thickness of 2.5 centimeter, weighing 30 to 40 gram. How you remember all this? I'm sure you'll find a way. So the length of cavity of uterus is 6 centimeter. You must be wondering, why should I know the length? Now there are some surgical procedures in which, such as DNC, where you're putting instruments inside the uterus. How much should you put it in? Should you put in a good 10 centimeter of the machine instrument inside? Then you are likely going to perforate the uterus, which happens, it happens. So that's why, or for example, you're putting an intrauterine device inside. How inside should you put it? Or for any hysteroscopy, or for assessing uterine abnormalities, you have to know the internal length of uterus. That is why this point was made. Now let's come to axis and position of uterus. Remember, your uterus is anteverted, anteflexed. Okay, so it is at a position of 90 degree. The cervix and the vagina are at an angle of 90 degree. The uterus and the cervix are at an angle of 125 degree. Okay, so 125 degree is your angle of anteflexion. 90 degree is the angle of anteversion. Believe me, this works. Okay, this is not only the way we do walk like an Egyptian. There are other ways of using these hands for something else. This is what I've used my hands for. Uterus, cervix, vagina. Uterus, cervix 125 degree, angle of anteflexion. Cervix, vagina 90 degree, angle of anteversion. V for vagina, anteversion. Okay. And so that's the angle of cervix. That's the axis of vagina, 90 degree. Axis of uterus, axis of cervix, 125 degree. Question, who maintains these angles? Why is the uterus doing this? That's because the round ligament of uterus, you can see it there anteriorly, is pulling the uterus forwards, making it lie forwards. What's the use of this angle? The use is that because the axis of uterus is different from that of vagina, it's not possible for uterus to prolapse. However, were you to lift up the uterus and make it straight, it would be easy for it to slide out of the vagina. Think about it. Okay. So here you are seeing a retroverted uterus. See how now the angle of vagina and that of the uterus are somewhat similar, and therefore uterus has ability to slide out. Okay. So found to be associated with prolapse of uterus. So I want you to now explore the following terms. Anteversion, anteflexion, we've done that. Retroversion, retroflexion, dextrorotation, levorotation. Please read up on this. So now here's the uterus. You're going to divide this into three parts: fundus, body, cervix. The body and the cervix are divided by a small little narrowing in the body of cervix called as the isthmus. It's the junction of upper mobile part of uterus to the lower fixed part of the cervix. If you're liking this lecture, do like and subscribe to my channel. Share your thoughts in the comment section. Share the video itself with your friends. Okay? Alright, let's continue. Remember, all the MCQs and notes related to every lecture are now available on the vbanatomy.com website. Please access those and study some more. Right. So let's describe. We understood fundus, body, cervix. Let's learn a little bit about each of these. First, fundus. Fundus is the blind upper end of the uterus, which is covered with peritoneum. Does it have a cavity? No. The body. Body extends from the fundus, where the two fallopian tubes enter, down to the upper end of the cervix or the internal os, or down to the isthmus. From the internal os to the external os is your cervix. So that's the extent of all these parts. Here is the body. It has an anterior, so I want you to think of it like this. It has an anterior surface and a posterior surface. The anterior surface is kind of resting on the urinary bladder, separated from it by the utero-vesical pouch. Can you see the pouch here? See how the uterus and the urinary bladder have a little gap in between, which is called utero-vesical pouch. As you can see, the peritoneum does not completely cover the uterus. It just stops short of the cervix. Posteriorly, similarly, the peritoneum covers the posterior surface, but here it extends on to the posterior fornix of vagina and forms a recto-vaginal pouch of ductless. Now, this relation of peritoneum is very, very important. I would like you to do this again. From the anterior abdominal wall, peritoneum comes down, covers the urinary bladder, but at the point just at the upper end of cervix, it gets reflected onto the uterus, covering the uterus, and from here covering the posterior fornix of vagina, and then continuing on to the middle part of the rectum, forming an anterior pouch called uterocycle pouch and a posterior pouch called recto-uterine pouch. Right. So like it has an anterior surface and a posterior surface, it also has two angles, the lateral angles. Okay. And below these lateral angles are the points where both the round ligaments are attached. So also are attached the two fallopian tubes. And here are the lateral borders now. Okay, I want you to look at the lateral borders here. This and this are the lateral borders. These are non-peritoneal. How do we understand this? Take a look. Now this is the same uterus that you were seeing from the front. Now I've just turned it and you are seeing it from the side. You can see how anterior and posterior surface of uterus is covered by peritoneum, but there is a gap in between them, which is non-peritoneal, which is the lateral border of uterus. In this lateral border, upper part, you can see attachment of uterine tube. In the lower part, you can see the uterine artery ascending along the lateral border. At the lower end of the lateral border, you can see how the uterine artery arches over the ureter. I want you to see this. The uterine artery arches over the ureter. This is called water under the bridge. I just love the term. I'll talk about it some more. Just remember, this relation of the uterine artery and the ureter is called as water under the bridge. Right. So we'll talk about the cavity of uterus. We've done lateral angles, we've done lateral borders. Let's talk about cavity. So the cavity of uterus is somewhat triangular when you look at it from the front. It's an anteroposterior flattened structure when you see a transverse section through the female pelvis. Okay. And it's an oblique slit when you look at it in a sagittal section as seen here. I've given you all these images because I want you to start using your brain to imagine. So were you to take a transverse section through the uterus, you will find that the uterus has 3 layers from inside out: endometrium, myometrium, perimetrium. Let's talk about these. Endometrium is this inner layer which is having a basal layer and an upper layer. The upper layer is shed off during menstruation. Below that, there is a layer called myometrium, which is made up of longitudinal fibers, some of which also extend outwards into the pelvic parametrium. It has an outer longitudinal layer, a middle. The layer, like I said, anchors the uterus and helps to contract and expel the uterine contents. It also has a middle circular layer, which contracts and holds the uterine contents inside. It has got a lot of blood vessels in it, which form what is called a stratum vasculaire. Please remember this. An innermost layer has got muscles going in various directions, okay, which are running around blood vessels. And they form what is, when they contract, they actually constrict the blood vessels, forming what is called as a living ligature. Can you see how they are constricting the blood vessel? This is what happens during parturition. When the baby is delivered, now there are open blood vessels. The muscles contract, closing them off, acting as a living ligature. How many layers did you see in muscle? Outer longitudinal, middle circular, inner reticular. Middle circular forms stratum vasculaire. Inner reticular forms a living ligature. Longitudinal helps to expel contents. Circular helps to hold contents inside. Clear? Now let's talk about the outermost layer, the perimetrium. Perimetrium is nothing but the peritoneum that is covering the uterus, intimately attached to the underlying muscle layer, stopping short of the cervix and posteriorly continuing over the posterior fornix of vagina. These are basics. You have to keep on repeating them to remember them. What is parametrium? We've done endo, we've done myo, we've done peri. What is para? Parametrium basically is the fatty and fibrous connective tissue that surrounds everything around the uterus. This is the zone in which you have blood vessels, you have nerves which are accessing the various viscera. Okay, so it contains uterine arteries, veins, lymphatics, nerves. Function is to provide structural support as well as provide an area for flow of movement of blood vessels. Remember, it is crucial in pelvic surgeries, especially in hysterectomies, for careful dissection. If you damage any blood vessels here, it can become a medical emergency. Also, during radical hysterectomies for cervical cancer, thorough exploration of the parametrium becomes very important. Let's now come down to the cervix. Cervix is a small, less mobile part of the uterus, which is barely 2.5 centimeter. Okay, it has an internal extent and an external extent. Inside, it extends from internal os to external os. Outside, it extends from the isthmus down to the tip of the lower end of cervix. It's widest in the middle and, like I said, most fixed part of uterus. See, what you see is that there is a isthmus and there is something called as a functional isthmus. Let's talk about this. Now, we've done quite a bit. Let's take a pause. Bring your coffee, all of you. Bring your tea. Bring whatever you want, but relax. We're going to go into something a little important. So let's talk about what is functional isthmus. See, isthmus was a narrowing of uterus continuing into the cervix. But what happens is that there's a small portion in the upper 1/3 of cervix which actually behaves like the uterus. It's called as a cervix, but it behaves like the uterus. It's covered by ciliated columnar epithelium. It undergoes regular menstrual changes. It is taken up by the uterus at the time of pregnancy for increasing the size of uterus. So it's called as the lower uterine segment. So basically, anatomically, we include it in the cervix, but it actually behaves as the uterus. So, but the fetal membranes don't get attached to it. So here is the difference between anatomical internal os and physiological internal os. Anatomical internal os is the internal os we spoke about. Physiological internal os is 1/3 part of the cervix below the anatomical internal os. Please think about it. Right. So continuing with our discussion on cervix, you can see that the cervix is directed backwards into the anterior wall of vagina so that the cervix gets divided into two parts. A supravaginal cervix, look at the diagram, it's very simple. Supravaginal cervix and the part which is lying in the vagina called as the vaginal cervix. Okay, so here's your supravaginal cervix, here's your vaginal cervix. Supravaginal cervix extends from the isthmus to the cervico-vaginal junction. Vaginal cervix is the part of cervix which lies inside the vaginal cavity till the external os. Now this is the cervix here. It's related laterally to a lot of very important structures. Take a look. This is the ureter. This is the famous uterine artery passing over the ureter. What is the line? I told you. Water under the bridge. Who is the water? Ureter. Who is the bridge? The uterine artery. Correct. The cervix is also related to the lower end of the broad ligament, and inferiorly on the sides it's related to the very strong McInrod's ligament, which kind of fix the cervix in place. Okay. You will also find here paracervical lymph nodes. These are lymph nodes which when they can become enlarged, and because their enlargement they can obstruct the uterus. We come to the paracervical lymph nodes. These are present on the lateral side of cervix. When they get enlarged, they can obstruct the ureter. Okay, so we must know about their existence. Let's talk about the vaginal cervix. This is the part of cervix which has entered into the vagina. As it enters into vagina, it divides the vaginal cavity into an anterior part, a posterior part, and two lateral parts. Each parts of cavity are called as fornix, F-O-R-N-I-X, fornix. Anterior fornix, posterior fornix, two lateral fornices. So the anterior fornix is non-peritoneal, posterior fornix is covered by peritoneum. We've done this, so we'll not discuss that. The lateral fornices are the two lateral spaces here, which are related to McInrod's ligament. So this is your anterior fornix. This is your posterior fornix. You can see how anterior is non-peritoneal and the posterior is covered by the pouch of Douglas peritoneum. So what is the clinical importance of posterior fornix? Understand that this posterior fornix is the direct entry into the pouch of Douglas just across that tiny little layer, right? So it's the gap through which you can access the peritoneal cavity without having to open the anterior abdominal wall. So you can have, it's a site for chaldosynthesis, it's a site from where you do vaginal tubectomies and so on. Take a look. This is how you're putting your needle through your syringe for aspiration or for any maneuvering in the pouch of Douglas. Very, very important. Recto-uterine pouch of Douglas. So continuing with the structure of cervix. Cervix is having the epithelium in cervical canal is simple columnar, and on the outside it is stratified squamous epithelium. The cervical canal shows a lot of folds. They are such that there are folds on one side and depressions on the other so that they fit into each other. These folds are called as arbor vitae uteri. There's also arbor vitae cerebelli. Find out what that is. Arbor vitae uteri, they fit into each other, closing off the cervix. Okay, what is ovula nibothi? Please find out. It's just a mucus gland secretions causing small cyst formation in this region. If you look at the cervix, okay, in a nullipara, the cervix is usually rounded in its opening, but in a multipara, you will find that the cervix is a transverse slit with an anterior lip and a posterior lip. Now we say the cervix is a fixed part of uterus. Who is fixing it? There must be something that's fixing it. So it is fixed in place by three ligaments that radiate out from the cervix. One that goes from the cervix to the pubic bone, called the pubocervical ligament, from the cervix to the pubic bone. From the cervix to the lateral wall of the pelvis and to the fascia covering levator ani, the transverse cervical ligament, also called McInrod's ligament, and one that goes back to the cervix, called the sacrocervical ligament, also called uterosacral ligament, which attaches the cervix to the posterior to the sacrum. So anteriorly pubis bone, laterally side of pelvis, posteriorly sacrum. Cervix is fixed. Okay, that's how cervix is fixed in place. So where are all these ligaments? They are present in this plane. This is cervix and this is the plane in which you find them. Just above the levator ani muscle and the fascia covering levator ani. Since we are talking about ligaments, understand that uterus is having other ligaments also, like round ligament, etc. Let's talk about those. So here we've seen this image earlier. You're seeing a band extending from the lateral angles of the uterus forward through the deep inguinal ring, superficial inguinal ring to the labium majus. This round ligament helps to hold the uterus in anteverted, anteflexed position. We've discussed this once, so I won't elaborate too much on it. So here's the round ligament on both the sides. Here is your urinary bladder and the vagina. And here you have what is called utrovesical fold. The peritoneum passes from the urinary bladder onto the uterus, creating a peritoneal fold, which is called utrovesical fold. It's just a fold of peritoneum. It's not really a ligament. Similarly, from the rectum to the vagina, there is a fold of peritoneum called the rectovaginal fold of peritoneum. On this side, I told you there are uterosacral ligaments. These are also covered by peritoneum, forming two side folds, which are called rectouterine folds. Now, I want you to note something now. In this gap, where there is rectovaginal fold and rectouterine folds, there is a pouch formed, which is called a rectouterine pouch of Douglas. We've done this repeatedly. I'm going to show it to you just one more time. This is, you're looking at rectouterine pouch from the top. Also dividing your pelvic cavity into an anterior cavity and a posterior cavity is, of course, the broad ligament double fold of peritoneum. We will discuss that subsequently. Let's quickly run through rectouterine pouch of Douglas, which comes as a short note for all of you. It's the most dependent part of pelvic peritoneal cavity. It's bound anteriorly by the vagina and the posterior fornix, posteriorly by the middle 1/3 of rectum. On the sides by the two uterosacral folds covered by rectovaginal peritoneal fold. The floor of the pouch is about 5.5 cm from the anus and 7.5 cm from the external vaginal wall. This is how you put in your needle or your syringe to access the rectouterine pouch of Douglas. I'm doing this again and again because this pouch is very important. Any pus or blood in abdominal cavity in a female gets collected here as it's the most dependent part. It's possible for you to access it through procedure called posterior colpotomy. What is it called? Posterior colpotomy. You don't have to open the anterior abdominal wall at all. Right. The other ligament we need to talk about now is the broad ligament. So what is broad ligament? It's a double fold of peritoneum. It's like you're dropping a peritoneal fold on the uterus on the left side and on the right side, completely covering the uterus. This double fold of peritoneum extends from lateral wall of the uterus to the lateral wall of the pelvic cavity. This is your pelvic cavity. This is your peritoneum, dividing the pelvic cavity into a utrovesical pouch in the front and a rectouterine pouch at the back. Okay? Each broad ligament has got two surfaces, an antero-inferior and a posterior-superior, and got four borders, superior, inferior, medial, lateral. Common sense, superior, inferior, medial, lateral. Let's discuss this in brief. So here you're looking at the same image that I showed you earlier. This here would be the antero-inferior surface related to urinary bladder and posterior-superior surface, which is related on both the sides to the ovaries attached to it with the help of double fold of peritoneum, and then beyond the pouch of Douglas related to the rectum. Take a look. So this is a section, okay, sagittal section through the broad ligament. Here's the fallopian tube. This is the antero-inferior surface related to the urinary bladder. This is the posterior-superior surface. you can see how the ovary is attached to the posterior superior surface with the help of double fold of peritoneum called mesovarium. Okay, see that fold, remember it, mesovarium attaching the ovary to the rest of broad ligament. The superior border of the broad ligament contains the fallopian tube, and in the lateralmost part, it forms a double fold of peritoneum which suspends the ovary called the suspensory ligament of ovary. This contains, here you can see that, it contains ovarian vessels and lymphatics and nerves which are going to the ovary. Suspensory ligament of ovary. Another name for this? Find out. So, inferior border of broad ligament reaches down till it reaches those two precious structures, uterine artery and ureter, water under the bridge. So, let's briefly discuss parts of broad ligament. You can see that this is the broad ligament. The part that suspends fallopian tube is called mesosalpinx. The part that suspends ovary is called mesovarium. The rest of it is called Myometrium, and the part that connects the broad ligament to the lateral pelvic wall is called suspensory ligament of ovary, which we discussed earlier. So what does this broad ligament contain? You've already seen it. It contains fallopian tube, it contains round ligament of uterus, round ligament of ovary, ovarian vessels, uterine vessels. We know all this. What we don't know is it also contains lymphatics, nerves, few muscles, and it contains some remnants like epiphyron, peripheron, and duct of epiphyron or Gartner's duct. These are all viva questions. The last part is clear viva question. Please study it. Otherwise, access my lecture on female reproductive system development. Right. So, what are the remnants of? Find out. If you don't know, of course, please feel free to message or comment in the comment section. I'll give you the answers. So all these ligaments that we discussed are actually supports of uterus along with a lot more. So I've created a separate lecture on supports of uterus. Please see that so that you will be able to put together the very important answer on supports of uterus, a very commonly asked long answer question as well as a 5-marker. So please do study it. Not only are these questions that are asked in exams, they are questions that are very, very relevant clinically. So please study the lecture on supports of uterus separately. There's also a separate lecture on surgical anatomy that is required for operating on uterine prolapse. You should be studying that as well. Right. So let's now come to what is the blood supply, nerve supply, lymphatic drainage and so on. Uterus receives its blood supply from uterine artery. What is uterine artery a branch of? So here you are seeing the common iliac artery dividing into external iliac and internal iliac. Internal iliac is giving rise to a number of branches, such as it's dividing into anterior posterior division, which is giving rise to a number of branches. One of the important branches here is the uterine artery, supplies the uterus. So here's your uterine artery. You can see it approaching the lateral border of uterus, giving rise to a vaginal branch and then giving rise to ascending branch. Vaginal branch supplies the vagina. Ascending branch begins to supply the rest of uterus, anastomosing with ovarian artery, which is a direct branch of aorta. So all this together forms the blood supply of uterus. We now take a section through the uterus. You will find you'll have to know a lot more. Here are your two uterine arteries. They're giving rise to branches that go in front of uterus and behind uterus to form a circle. They're called as coronary arteries. Each coronary artery now gives rise to radial branches which enter into the underlying musculature, creating stratum vasculaire, a stratum within the muscle layer. From here, basal branches and spiral branches enter into the endometrium. The spiral branches are the branches which will be torn in the menstrual cycle, and the basal branches are the ones that will help in regeneration of the endometrium at the end of every menstrual cycle. So that's the blood supply of uterus. What about venous drainage? The venous drainage will correspond. It's observed that these veins, visceral veins, form venous plexuses. So you can see a uterine plexus here, you can see a vaginal venous plexus here around the viscera. In all the pelvic region, such plexuses are formed. Nerve supply to both uterus and vagina is by sympathetic and the parasympathetic through pelvic splanchnic nerves. The lymphatic drainage is something asked very often. Pause, understand, think. The upper half of the uterus, okay, drains into para-aortic and pre-aortic lymph nodes, okay, but the angle of uterus, the lateral angle of uterus drains along the round ligament of uterus to the superficial inguinal lymph nodes. So you might find superficial inguinal lymph nodes becoming thickened in case of a uterine pathology. The upper one-third of uterus, the upper half of uterus drains into external and internal iliac lymph nodes. Also the obturator lymph nodes. The lower half of the uterus drains and the cervix drains into sacral lymph nodes, external iliac lymph nodes and internal iliac lymph nodes. The upper half of vagina drains to the external iliac lymph nodes, lower half of vagina to internal iliac lymph nodes. Pause. Very important. Lowermost part below hymen again drains to superficial inguinal lymph nodes. All this can be understood in one single screenshot. You feel free to take it and study it. So what have we learned up till now? We've learned about what is uterus, we learned about its subdivisions, fundus, body, cervix. Then we talked about ligaments, then we talked about additional ligaments of uterus, blood supply, nerve supply, lymphatic drainage. Okay, let's take a quick look at the gross anatomy of uterus before we go further. Here's the fundus, here's the isthmus of uterus, therefore body and then cervix. You can see the external os of uterus here. This is the uterine tube, isthmus, ampulla, infundibulum, and fibria. This is the parts of broad ligament, mesosalpinx, mesovarium, mesometrium. This is a suspensory ligament of ovary, supplying blood to the ovary through ovarian vessels. Here's the round ligament of ovary and the round ligament of uterus. Here's the uterine tube. Basics. What about the vagina? Let's touch it in very brief. Extending from the cervix down to the the outer vaginal opening. Anterior wall being much shorter than the posterior wall, 7.5 to 9 centimeter ratio, at an angle of 90 degrees with the cervix. The anterior part of the vagina is non-peritoneal, in the upper part related to the urinary bladder. Lower part, it is sharing a wall with the urethra. Posterior wall can be divided into upper 1/4, which is related to the recto-uterine pouch of Douglas. Middle 2/3, which is related to the rectovaginal fascia and ampulla of rectum. Lower 1/4, which is related to the perineal body and anal canal. You can see those things here. The vagina on the side is related to a lot of structures. Again, the famous water under the bridge, ureter and uterine artery. Below that, it's related to the McInrod's ligament and the other ligaments, pubocervical and uterosacral. Below that, it's related to the levator ani muscle. Below that, the urogenital diaphragm. And below that, contents of the superficial perineal pouch. So these are all the relations of the vagina. The vaginal wall is made up of mucosa, muscle layer, fascia and serosa. With this in place, let's briefly touch upon what are the pathologies that can happen to the vagina and uterus. The uterus can develop most commonly fibroid formation, which is small smooth muscle benign tumors, which can be variably classified. You have fundal leiomyoma, you have a submucosal leiomyoma, intramural leiomyoma, you have a pedunculated leiomyoma or fibroid. It's a very common pathology and do not forget to write about it. Prolapse of uterus is a topic by itself which I have covered in another lecture. However, remember it's a very common problem. Usually during delivery, if the McInrod's ligaments are damaged and not repaired, or if the uterus becomes retroverted, or if the pelvic floor becomes weakened, or with age, the uterus can prolapse down, causing prolapse of uterus. There's also a condition, so like I said, there's a separate lecture on the surgical anatomy of uterine prolapse. In this, I also talk about briefly about some developmental anomalies. Okay, we will now go on to talk about endometriosis. So what happens sometimes is the endometrium-like tissue not only lines the uterine cavity, but develops in other part of the female anatomy. So it can develop on the surface of uterus, along the ovary, along the lateral wall, even in the nasal mucosa. And at the time of menstruation, each of these tissues undergo the regular changes and they bleed. This causes severe discomfort to the female, okay, and is also associated with infertility. It's a condition which has been observed very frequently nowadays and must be mentioned in pathologies or applied anatomy of uterus. Endometriosis. These collections are called as endometriomas. So what did we learn today? We learned about uterus, fundus, body, cervix, ligaments attached to the uterus and cervix. We learned about blood supply, nerve supply, and lymphatic drainage of uterus. We touched briefly upon the vagina and some of the applied anatomy. The uterus is a topic which we can discuss for hours on end, but still I have tried my best to give you the necessary details required for initial understanding of the uterus. Do feel free to ask me any doubts on or put your doubts down in the comment section. There's a separate lecture on supports of uterus, separate lecture on the surgical anatomy of required for uterine prolapse surgeries. Please see those as well for further detailed understanding. If you liked the lecture, please share your thoughts in the comment section, like and subscribe to the channel, and share the video with a friend. Thank you, my dear students. Please remember, MCQs and notes on all my lectures are now available on the website bbanatomy.com. Please feel free to access those. Just keep studying. Alright, I hope this lecture helped you to understand uterus. I'll see you across the screen in some other video. Thank you. Bye.